I like to use the term time in bed restriction because, first of all, it's less spooky for both the clinician and the patient who has the idea of, oh my gosh, I only sleep X number of hours and you're asking me to sleep even less than that. That can create a lot of anxiety. Time in bed is a much better accurate representation of the data, where there might be a slight reduction in the first week when the sleep systems are being re-regulated, but actually there's not a significant reduction in time spent sleeping, rather just amount of time we're spending awake.
I'm here with Dr. Parky Lau. Today we are talking about how to implement CBTI in the clinic, in the real world. We're going to go through it using 2 case examples, specifically talking about menopause and patients with bipolar disorder. Let's start by talking about how you build a case formulation for someone with insomnia, and what would that look like for the patient going through menopause versus the patient experiencing bipolar disorder.
When I think about what case formulation is, I see it as like a fancy $50 term for what is it that is maintaining this person's insomnia. And usually when we think about this in the context of chronic insomnia, we can start from the beginning of people with insomnia are obviously very anxious about their sleep and not being able to sleep. And as a result, they start to engage in what we call compensatory behaviors, which are these kind of short-term things that work really well, but in the long term actually contribute to problems over the long term. And these things include like taking naps or trying to spend more time in bed or getting really anxious about their sleep. So they're doing everything possible to be able to get some sleep at night, which of course counterproductively actually impacts their sleep. And as behavioral sleep medicine clinicians, we often think about 3 main factors that contribute to chronic sleep problems. And this is important because we can often have 50 different strategies that we can give to patients, but we want to make sure that we're giving the right one for them. And the 3 that we focus on are sleep drive, which is like our appetite for sleep. So the longer that we don't eat, the hungrier we get, the longer that we are awake, the hungrier for sleep we are at the end of the night. Our circadian rhythm, which is our sort of timing of when do we prefer to go to bed and wake up, and certainly having irregular schedules can often impact our ability to get a strong circadian signal. And then hyperarousal, which is our fancy catch-all term that basically makes it hard for us to sleep if we're really anxious about sleep, if our mind is wired, if we're noticing that the bed has become this place of frustration and anxiety. All of those things can contribute to chronic sleep disturbances. And our goal is to figure out what of these are maybe the most contributors, the biggest factors for this person's sleep problems, and pick the right strategy for them. And specific to your question about menopause and bipolar, for people in the menopausal transition, the biggest factor that impacts their sleep are these kind of vasomotor symptoms like hot flashes and night sweats. And we want to be thoughtful of how does that impact their sleep and perpetuate sleep problems, and how can we support them in that context? How can we make sure that they're feeling confident and comfortable when these sleep disruptions naturally occur? And then in the context of bipolar, we want to be thoughtful about the formulation there too, because oftentimes some of the recommendations in CBT for insomnia may or may not exacerbate some of the symptoms associated with variable mood fluctuations. So we want to be thoughtful towards that piece and make sure that the recommendations we're providing for them is highly efficacious while also maintaining a level of safety. And we can, of course, talk more about that down the road.
Excellent. And just to recap, so we're looking at the compensatory behaviors that patients are engaging in. And then I love the 3 pieces that you shared. I call that the CSH framework: the circadian rhythm, sleep drive, hyperarousal. And those are the 3 aspects to really look at when you're working with a patient who has insomnia. And for you, if you're listening, if you're a clinician and you're not a sleep specialist or you're not a behavioral sleep specialist, you can still use these principles with the patient in front of you. If you're waiting to get them into a referral with a CBTI practitioner or getting them into some kind of program, you can still start to implement some of these things. So we'll talk about that as we go through the discussion. Okay, so now we have this case formulation and we're wanting to apply some CBTI principles. Where do we start? How do you know what to begin with? And then how would we adjust it for the patient with menopause? And again, the example for the patient who has bipolar disorder. Let's talk about where to begin.
Starting with where we begin, I think oftentimes it's quite helpful to get a general history of the person's sleep problems, understand a little bit more of their sleep patterns. So this can be done in a couple of ways. One is through a sleep diary, where a person kind of night to night tracks their sleep so that you get a general sense of what's going on with their sleep patterns. But if that in the moment is a bit tricky for you, then even just getting a sense of what time are you usually going to bed? When are you waking up? How long does it take you to fall asleep? How long are you up in the middle of the night? What are some of the thoughts that are going on during that time? All of that provides really nice, valuable information to determine, for example, are there anything impacting our appetite for sleep, our sleep drive? So maybe this person is sleeping 7 hours, but they're spending 10 hours in bed. So all of a sudden, their sleep pressure might be, or sleep drive might be a little bit lower if they're taking naps during the day, or if they're sleeping in on weekends. All of that provides really nice information surrounding how much sleep drive they're building up, whether or not their circadian rhythm is nicely set and timed in terms of regular bed and wake times, or if there's really scary, anxious thoughts that might be contributing to hyperarousal and making it hard to sleep at night. Because if you're super anxious and you're wired up, it's going to be hard for us to have sleep take us away into the bedtime. So those then provide valuable information as to what the specific strategy could be. So if this person is spending a lot of extra time in bed, then it might be helpful to engage in something like time in bed restriction or sleep restriction therapy to bring how much time they're spending in bed a little bit closer to how much they're sleeping. Or if they're napping, that might be some place to eliminate or limit naps to ensure high amount of sleep drive down the road. So again, we can talk more in detail, but these are some of the things that help us identify what might be some of the strategies that might be more useful for that particular individual that's in front of us. Within the context of menopause and bipolar, some things that we might think of would be, of course, again, these vasomotor symptoms, these hot flashes that happen is usually in the middle of the night that perpetuate middle of the night awakening. So oftentimes one of the things that can be helpful would be to plan ahead with the patient. Okay, these things are likely to happen at night. Are there ways that we can support you during that period of time to make sure it's most comfortable for you, so we're not associating that time as a time of distress and discomfort? Are there ways to reduce the symptoms as soon as possible? Maybe we can have a nice cup of water next to you, or a fresh change of clothing, or to keep the bedroom a little bit cooler. In the context of bipolar disorder, we might be thoughtful as to, okay, so we don't want to necessarily exacerbate the symptoms. Shortened sleep durations can be a risk factor for a manic episode, for example. So in this context, we might say, let's start with maybe regularizing the schedule a little bit. And then as we can continue practicing, we might start to, instead of immediately restricting time, going from, let's say, 10 hours to 6 hours, maybe we'll go from 10 to 9 hours to 8 hours time in bed, just to create a little bit more of a gradual pacing for this particular individual, where a manic episode might be something to be more considerate of.
You mentioned the sleep diary. Is there one that you like or that you would recommend to the clinician or even a layperson who's watching? Is there one that you prefer?
I think people will have different preferences. Some people like to have it as part of an app, for example, where there's a free CBTI coach app where people can download that and kind of just use that to track their sleep. Other people who prefer a more pen and paper or PDF copy, they can find sleep diaries online. If you search up Stanford Sleep Diary, you'll be able to have access to a free PDF file, and you can track your sleep on night to night. And it's important to know with a sleep diary, no need to be perfectionistic about it. Feel free to write the numbers that feel right for you. Take a moment in the morning to do so that it doesn't feel like a clock watching activity where you constantly have to look at every single number and make sure everything's perfect. Your best guess is the best answer.
That's really helpful because one of the questions I'll get from other clinicians is, okay, if my patient's doing a sleep diary and they wake up in the middle of the night, should they look at the clock to check the time? Because normally we tell them don't look at the clock. So what would you recommend?
I would say I absolutely agree with that. Make sure to not be doing too much of the sleep diary, looking at the clock. Oftentimes, especially with the people with insomnia, they look at the clock, it's 3 a.m. and they're like, oh my gosh, I only have X number of hours left to sleep. And I think for the most part, it's best to do it in the morning.
Okay, perfect. So your best guess, like you said.
Exactly.
All right. So going back to the sleep restriction or the time in bed restriction piece, I know a lot of clinicians are maybe a little bit nervous about implementing that, especially with the bipolar disorder patients. So you did mention the kind of sleep compression instead of the sleep restriction strategy. But what's a good patient-friendly way to introduce them to the concept of sleep restriction and to help them implement it in a way that is sustainable and successful for them?
Some things that I can think of when it comes to making sure that this is as comfortable as possible. First is to kind of navigate the clinician's own response to the idea of sleep restriction therapy, where oftentimes we use the term sleep restriction therapy, that's the formal term, but I like to use the term time in bed restriction because, first of all, it's less spooky for both the clinician and the patient who has the idea of, oh my gosh, I only sleep X number of hours and you're asking me to sleep even less than that. That can create a lot of anxiety. And time in bed is also a much better accurate representation of the data, where there might be a slight reduction in the first week when the sleep systems are being re-regulated, but actually there's not a significant reduction in time spent sleeping, rather just amount of time we're spending awake in the middle of the night or during the nighttime. And then the other piece is that once the initial restriction occurs, what usually happens is that a person, as their anxiety about sleep reduces, as their sleep systems become more re-regulated, there's actually an increase in the amount of sleep that occurs after the initial restriction period. So in reality, people who engage in restriction start with the quality first, but then they expand their time in bed window to make sure that they're getting all the sleep that they need. So it's actually going to increase both the quality and eventually the quantity of sleep. So it's helpful to recognize from that framework that we're just reducing the time in bed spent awake rather than reducing sleep opportunity in general. So that's one thing that's important to note. And then one analogy I often find with patients that can be really helpful is the pizza dough analogy, where essentially, let's say you had 7 inches worth of pizza dough, but you're stretching that into a 9 or 10-inch pan. I usually like to ask the patient, what would happen if you were to do that? And they'll say, yeah, it'll get burned. There's holes in the middle of it and it'll be really thin. And I do the same with time and bed restriction with the idea where if we're sleeping 7 hours, but we're spending 9 or 10 or 11 hours in bed, our sleep becomes the same as the pizza dough. It becomes really light. There's a lot of awakenings in the middle. And all we're doing is bringing the pan a little bit closer to how much sleep dough you're producing, where when patients understand the why as to why we're doing this, it shifts the framework and the narrative from I'm losing time sleeping to I'm just getting kind of sleep that's a little bit more fulsome and actually feels good for me. And that then allows them to not feel like this is a scary experiment, but really something that's actually going to help with their quality. And I think that framework will be helpful for both the clinician as well as the patient to manage the potential anxiety or fear of what the patient's going to say to, oh, now you're just sleeping 7 hours or only have 7 hours of sleep.
I really like that pizza dough analogy. I think that kind of hammers it home and it makes a lot of sense. And
Exactly.
using those sorts of like visual metaphors and analogies, it clicks for patients. Like they really understand it. I want to dig into the sleep restriction or time in bed restriction just a little bit more. And I love that you call it time in bed restriction. And another term that I find helpful for my data-driven folks is calling it sleep efficiency training. They like that sort of mindset. Oh yeah, I'm going to improve my sleep efficiency. How do we actually implement it? Let's say you have a patient in front of you who says, Doc, I'm getting only 3 hours of sleep every night. You find out they're spending, let's say, 8 hours of time in bed. What's the next step? What would you recommend? As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
So I guess one caveat is that typically the sort of recommendations based off the evidence is that we usually take how much a person is sleeping and we add about either at 30 minutes or we keep it to consistent to total sleep time. So if they're sleeping 6 hours, we would say 6 hours time in bed or 6.5 hours, depending on patient as well as therapist or clinician preference. When it comes to patients who report a very low objective total sleep time, like 3 hours, then we usually have a bit of a cutoff. We say, okay, we want the minimum to be 5 or 5.5 hours. Again, there's a little bit of difference depending on the literature and depending on the protocol. But let's say in this case, the minimum is 5.5 hours. So even if a patient is sleeping 4 or 3 hours, we would give them at least 5.5 hours time in bed. And of course, we're collaborative in the nature of when this person wants to go to bed and when they wake up. So if they're like, I need to wake up every day at 6 a.m. or I prefer to wake up at 7, then we can take the 7 and work our way backwards 5.5 hours, for example. With respect to this lower total sleep time, the other piece that can be often helpful in conjunction with time in bed restriction is something we call, of course, you might already know, stimulus control, where we don't go to bed unless we are feeling sleepy. So if your earliest bedtime is 1:30, but you're like wide awake at that time, then one thing we can encourage you to do is to continue doing something you enjoy, something that could be relaxing. It could be watching a show, reading a book, listening to a podcast. And then once you notice the cues of sleepiness, that's when you go to bed. So we can catch you on both ends of, even if you're right now not sleeping the entire 5.5 or 6 hours, that you can then wait until you do feel that sense of sleepiness and then go to bed at that time.
That really illustrates that sort of personalized approach that we're talking about.
Yeah.
Okay, so you've talked a bit about sleep compression. You've also mentioned counter control previously. So can you explain what that is and when might you implement those types of approaches?
When it comes to counter control, fundamentally the idea behind stimulus control and counter control is we want to make sure that the bed is associated with a place of sleep and relaxation and calm, such that we don't want people to be in bed frustrated, tossing and turning, like just having sort of a very active mind, because then the bed in the bedroom becomes associated with all of that. And for people listening, if you've ever had the experience where you went to bed feeling sleepy, but the moment your head hit the pillow, you were wide awake, then that's a good indication where that maybe some amount of conditioned arousal has started to happen where the bed has become associated with all that jazz and all the sort of noisy environment. So one thing that can be helpful to understand as part of counter control is we don't necessarily have to get out of bed in order to get the benefits of making sure that the bed is associated with calm and relaxation. So if you do wake up in the middle of the night, for example, and instead of getting out of bed, you decide to sit up and read a book or do something relaxing until you do feel sleepy again, that would likely have, at least in principle, the same impact as getting out of bed. So in this context, oftentimes the people that might benefit a lot from counter control are the people who may be living with a lot of roommates and they don't want to go outside because it might bother other people, older adults who might be at fall risk, pregnant individuals where it might be an issue of safety to get out of bed constantly, as well as people just generally waking up a lot in the middle of the night because the research indicates that counter control, staying in bed as long as you're relaxed, works just as well as stimulus control, especially for these middle of the night awakening. In line with kind of personalizing the treatment and make sure that for safety, for tolerability, for comfort, it makes perfect sense for some people to just stay in bed as long as they're able to do something they enjoy.
That's so helpful because one of the things that I hear from patients a lot, I'm sure you hear the same, is they don't want to get out of bed in the middle of the night and they feel more awake. Now they're cold and they're up and they're more active and they're moving to another room and now they're wide awake. So the counter control strategy it's really great. It's great to hear the research on that it can be just as effective as the stimulus control piece. Can you explain sleep compression? What is that and how do you implement that?
That's a great question. So with sleep compression, fundamentally the idea between compression and restriction is that restriction basically gets you all the way there. If let's say this patient is sleeping 6 hours and they're spending 10 hours in bed, so you're just bringing them all the way down to 6 or 6.5 hours of time in bed, where oftentimes many patients benefit from this approach. They understand the principles very well and they get a lot of benefits, immediate benefits from the use of a more standard time in bed restriction. On the other hand, there are some patients, for example, individuals who struggle with bipolar related disorders or patients who are just super, super anxious. Like they understand the rationale, but they're just like, no, like that's just too scary for me. And in which case you might think, okay, like this person, we could bring them down to 6 hours, but it's likely that their anxiety is going to rise so high, it's actually going to counter any increase in the relevant corresponding improvements in sleep pressure. So this is actually going to be a horrible experience for them. So in this case, it might be worthwhile to take a more graduated taper and say, okay, so, going from 10 to 6 sounds like a little bit too much for you, at least at this time. Why don't we go from 10 to 9, then to 8 to 7? So then we can take a more gradual approach. The person gets more and more evidence that this is something that's not totally crazy and will actually support their sleep. And then in which case they can have more and more buy-in and more adherence instead of either doing it and having a terrible experience or not doing it at all. And then again, having a sort of a quote unquote failure experience. So in this case, it can often be quite helpful from an adherence side, especially if anxiety, as well as, of course, in terms of bipolar, that where we're managing risk. So I would say in that case, time in bed compression can be quite helpful. And in terms of how you might go about it, I'm sure there's different protocols, but you might go instead of, if there's a 4-hour difference, you might go by 25%. So you might go 1 hour each week until the person gets to their goal time in bed.
Okay, this is so helpful because I think a lot of times when people hear about CBTI, whether they're a clinician or they're a layperson, maybe someone who's struggling with sleep, it can feel like or sound like CBTI is very rigid. But as you've been explaining, there are all these different tools and there's different ways to tailor it to the person who's struggling so that they can find a system that works for them within the evidence base. So what are some of the common mistakes that you see clinicians making when they're trying to deliver CBTI and maybe they're getting a little too rigid about it? And how would you do things differently going back to our patient with menopause versus our patient with bipolar disorder?
I would say one of the biggest mistakes I see clinicians having is doing the what without really understanding the why underneath it. They're saying, oh, this person's sleeping 6 hours, so let's give them 6 hours time in bed. This person seems to have some amount of conditioned arousal. Let's just make sure they get out of bed. And although these make sense from a complete science perspective, it's not really taking into account the individual person who has to take on these recommendations, which, as we know, the behavioral strategies, while extremely effective, also are very hard to do. And if we don't do it with a sort of a human touch, then it becomes easy for the patient to feel hopeless and despondent and potentially drop out of treatment. So one thing that can be quite helpful is to be really thoughtful as to what this person is going through and how can we make sure that we're thinking about the case formulation, thinking about what are these impacting factors surrounding sleep pressure, sleep drive, circadian rhythm, hyperarousal, And how can we move them towards these North Stars in a way that feels right for them? So maybe in the context of people with menopause, how can we make sure that middle of the night, instead of going out into the cold, is something much more comfortable? Like you noted, maybe being able to sit in bed, but being nice and cozy and having a nice cup of water or something along along those terms to make sure that they have that experience as enjoyable as possible. Or in the context of bipolar, thinking about regularity being the sort of top recommendation instead of immediately going for time in bed restrictions. So we're just really being thoughtful as to what are the things that allow me to be a real human in the room and make sure I'm understanding the patient's experience properly and empathetically, while at the same time being thoughtful about these sleep recommendations and the principles of sleep regulation so that any recommendation I'm providing is tailored to their unique needs and situations and moves them closer towards their goals.
I love how you're emphasizing the regularity, that sort of circadian entrainment with the bipolar patient, because that is such a core feature of bipolar disorder, and the rhythms can get really out of control. And so helping them regulate that is such an important piece of treatment. Whether or not you're supporting them with sleep, even if you're a psychiatrist and you're listening and you're working with bipolar patients and you're not necessarily supporting them with sleep, helping them establish a really consistent circadian rhythm is going to help improve their outcomes and reduce the risk of mania and depression. Now, you're working with this patient, and what I often find is that at the beginning of treatment, there's sometimes a lot of excitement going in. They're like, okay, I'm doing something now, and I've got a plan. And then maybe there's an initial improvement, and then a couple weeks in, they might be going, but wait, I'm still not sleeping, or I'm doing everything, and maybe they're starting to lose hope at that point. What would you do? How would you troubleshoot this and support them?
One thing that I think of when I don't have an immediate answer is that if I don't have an answer to a certain question or statement, then that means I don't have enough information. I would be really curious about when they say, for example, I'm feeling a little bit hopeless, this doesn't feel like it's really working. I'd be curious about getting a little bit more granular as to what is actually going on. When you say, this isn't working, tell me a little bit about what you mean. Oh, I'm still noticing it takes me an hour to fall asleep. Okay, tell me a little bit about your experience during that time. What's usually happening? Are you choosing to go to bed because it's 12 and we said 12 to 6? Are you going to bed because you're feeling really sleepy? Once you do hit the pillow, what's usually going on in your mind? I'm thinking, I only have 5 hours left before I have to wake up. So tell me a little bit more about that. How do you think that kind of increases your sense of anxiety? It makes me feel really frustrated and scared, and I'm worried about the next day. Okay. This then provides a lot of valuable information to input into our little case formulation as to, okay, these are some specific anxiety thoughts that we can maybe target, certain behavioral changes that we can shift so that they're going to bed when sleepy instead of just because it's a specific number. So one thing that can be often helpful to support case formulation is, of course, getting a little bit more data as to what's actually happening when a patient experiences discomfort or they're experiencing lack of improvement. How do they define it? What might be some of the things that maintain it? Again, from that sort of case formulation, 3 main principles perspective. And then providing, again, that sort of specific key that unlocks the patient's door. And then that allows us to get a little bit more clear as to what's going on for them, and then the specific strategy that allows them to resolve the issue.
That's really great advice, just digging in to see what's going on and sometimes even exploring with them, what does progress look like for you?
Exactly.
And maybe just even acknowledging that sometimes progress is having less anxiety about sleep and not necessarily getting more hours initially,
Absolutely.
even though that's the goal for a lot of our patients. But there may be different markers of progress to explore as well. So yeah, I really like that. Now, many of our patients struggle with letting go of sleep effort. And patients who struggle with anxiety, with perfectionistic traits, I work with a lot of people we're both in the Bay Area. We see a lot of people in tech. And so they're used to being in control and measuring the data and putting a lot of effort. You work hard and you get a good outcome, get good output, but sleep doesn't work like that. So how would you work with these patients who struggle with letting go of effort and control?
That's a really great question. And I think there's a number of different factors that can support this letting go of control. One is by helping them really understand the sort of sleep regulation principles and why these strategies can be helpful. So if they can understand, this makes very good sense as to why I'm spending less time in bed or why I'm getting out of bed, even though in intuitive sense, it makes a little bit less sense, but counterintuitively, they can actually really support the sort of regulation of sleep principles. So even being able to help them by joining them and helping them understand, for example, let's say in the context of conditioned arousal, where we might talk about the idea of Pavlov's dog and the ringing of the bell and how in some ways the bed has become the ringing of like frustration and tossing and turning of them, and then asking them the question, if we were to try and break this association, make sure that the bed is no longer associated with worrying and tossing and turning, what would you do? And then they might be able to say, oh, I probably wouldn't be spending so much time awake in bed or working in bed. And that allows them to come up with the understanding and the ideas themselves, which I think is often a lot stickier than doing a sort of doctor said orders. And that usually, especially for people who are high powered and high functioning, are like, I don't want to listen to my doctor. I think I know better than that. So I think often that times that sort of deepened understanding can often be helpful. It can also be quite helpful to join with the patient that in a lot of ways that your need for control and tendency actually has served you so well. You've done so much good in your life. And in the context of sleep, as we know, is an effortless process. That's where the sleep effort becomes a little bit trickier and becomes a little bit less helpful. And a little analogy or a little experiential exercise I like to use is this sort of finger trap analogy where we're basically trying to force ourselves out of this trap. Like we're trying to force ourselves to be able to sleep, but it's really being able to let go of that effort to be able to break out of it. And oftentimes that experientially allows people to feel a little bit more comfortable with the idea of and being more willing to try what it means to not take effort and put effort into our sleep. I think one last piece that can be often helpful to increase a sense of willingness is to know that the treatment is inherently a short-term treatment, that we're really trying this as in some ways experiment to see how this can change the sort of parameters of your sleep. And this is not a life sentence. Why don't we try this for a week and we can hold and suspend belief for a moment, and then we can then get the data. So joining with them of their desire for data to see if these different strategies can actually be helpful or not and towards their goals. And then that allows for a little bit more flexibility to give them a shot.
I love the finger trap. I think that's such a powerful visual. And you shared the pizza dough analogy as well, and the Pavlov's dogs with the bell. I think these are all really great metaphors and visuals that help people understand what you're working on. Are there any other visuals or metaphors that you like to use, especially going back to our menopausal patient? Is there anything specific that clinicians can take away that they can use with those patients, and then also with the bipolar patient?
One other metaphor or analogy I like to use imagery, especially when it comes to more mindfulness-based interventions, especially with our menopausal folks, are things like letting go in terms of watching, for example, leaves on a stream, treating our experience or our thoughts as leaves on a stream or clouds in the sky passing away. Oftentimes when we have experiences like a hot flash in the middle of the night, it's very distressing and we often take a very strong reaction to these negative experiences like, why is this happening again? This is horrible. And almost adds secondary suffering to the pain that's already happening. So some of these metaphors and analogies of being able to let go, take a more mindful stance to the experiences in a non-judgmental way can be a really great way to be able to let those experiences pass without adding fuel to the fire. So I think oftentimes that can be quite helpful as one way to support that. I think with respect to bipolar, I have less analogies and interesting metaphors for that, but oftentimes certainly understanding how sleep and mood can be very well interconnected, as you noted, this regularity piece being extremely important insofar that bipolar treatment even has an interpersonal social rhythm therapy where we're trying to keep bed and wake times pretty consistent, where we're trying to make sure that other things like the routine are kept consistent. All of those things can be really helpful to make sure that the patient knows that we're not just improving sleep, but we're also improving the mood as well for them.
What's one mindset shift or simple practice that clinicians can adopt to improve their CBTI skills? Maybe even if they're not a CBTI practitioner, but they're interested in applying some of these in practice. What's one thing that they could adopt today?
I think the biggest thing that I think people can adopt is understanding that yes, CBTI can be complex. Yes, sleep can be very complex. And at the same time, when it comes to behavioral sleep medicine and chronic insomnia, we can really look for our guiding stars with the three things that kind of really contribute and maintain sleep problems like sleep drive, circadian rhythm, as well as hyperarousal. So just being on the lookout for, are there any behaviors that could be making this person less hungry for sleep? Maybe they're taking naps, spending too much time in bed. Maybe there's something impacting their circadian rhythm. Maybe they're sleeping in on the weekends and there's a lot of variability in when they go to bed and wake up. Or if there's a lot of sleep anxious thoughts, or they're just worried about life stressors, and being thoughtful as to, okay, if that's the thing that's bugging them, what's something I could help recommend to be able to increase their sleep drive, set their circadian signal a little bit better, like getting some sunlight or waking up at the same time, or targeting some of these sleep anxious thoughts. How can I support that? And there's a whole host of tools that you can use. So it's like picking the right key for the lock in front of you. And honestly, like for example, if someone is just really generally anxious, you as a clinician may have many different tools to do that. You could do that through relaxation exercises, journaling, stimulus control, getting them get out of bed when sleep is not coming. So there's so many different possibilities, and all of them could lead to Rome in a sense of pick the ones that feel right for your expertise while understanding these main principles of sleep regulation.
What if you're a clinician and you're working with a patient or client who's been dependent on sleep aids for a long time? Maybe it's been a few months or even years, and they're really scared of coming off, but you know that you can support them in other ways. What would you say to that person who's scared of coming off their sleeping pills?
Yeah, for sure. I would personally come from a place of validation and joining the patient. It makes a lot of sense that, the years, given how much you've been struggling with sleep problems, that it feels like the medication is the only thing that can help support your sleep. So it makes sense that you're a little bit worried about the idea of getting off of it, even though I'm sure if push came to shove, like you would prefer not to use the medication. And I think one other piece that can be quite helpful is to help then talk maybe about the cognitive behavioral therapy for insomnia CBTI if they are looking for that service. That oftentimes what we find is that people who go into CBTI, they learn to develop and re-regulate their sleep system. They learn to sleep well and feel more confident in their sleep self-efficacy, that they and their body, they can trust their body to be able to produce the sleep that they need. And in a lot of cases, some people just spontaneously stop using. They think, oh, I actually am starting to sleep really well. I don't feel like I really need it anymore. And then they get off of it completely. On the other hand, there are some people who prefer a more gradual taper. So the clinician can work with them to slowly get off the medication. And as the person gets more and more confident about the fact that their sleep continues to be maintained and improved despite the reduction in medication, then the more their self-efficacy about sleep develops over time, and then they can get off of it in a more gradual pace. So both pathways are definitely open. But I think for me, I would instill a lot of hope that CBDI can be really helpful and in some ways doing the things that they feel like the sleep medication was doing for them, except now they can trust their body to do the same.
Yeah, I really like that approach of the validation and then explaining the science behind CBTI, how it works, and then the very gradual taper and reduction of the medication works for most people and important depending on what type of medication they're on.
Exactly.
Some shouldn't be stopped cold turkey. And we do have a video on the new tapering guidelines from the American Society of Addiction Medicine on tapering off benzos. So you can check that out if you want to learn more about the latest guidelines around tapering benzos. Okay, what do you wish someone had told you when you first started practicing CBTI? Anything that you wish you knew when you first started, or maybe some mistakes that you made early on that could be avoidable for others who are just learning?
Yeah, I would say the biggest one that I wish I had learned earlier or at the beginning of my training career was to not make the patient's anxiety my anxiety, in the sense that oftentimes when patients hear these recommendations, they're going to very reasonably have a little bit of an anxious response and push you away from where it hurts, like where you push and you feel where it hurts and they're like, no, let's not touch that part anymore. Especially for things like I remember my first patient, we were doing time in bed restriction. They were sleeping 7 hours, but spending maybe 10 hours in bed. We were thinking, let's bring it down to maybe 7.5 to make sure that you're not spending too much time awake. So they went about it, they tried it, and they came back keeping their schedule basically the same as when they came in. And they were like, actually, 7.5 feels a little bit too much. Like, I feel like I would do better at 10 hours or 9 hours. What do you think about maybe we increase how much time we're spending in bed? I feel like I'd be less anxious about it. So I think that would work better for me. And I was like, I don't really know how to respond to that, so let's just do that. And of course, in that way, I wasn't properly serving the patient because now they're just back to exactly where they were after 2 weeks of time with me. And one thing that would have been helpful for me to know is that when I hear a person's anxiety, that's information for me to be able to learn and address it rather than immediately making their anxiety my anxiety. And now we're both anxious. And the anxiety, what it wants is to not try anything new and stick to the status quo. So we want to be thoughtful as how we manage both our own anxiety and the patient's anxiety so that we're tailoring and responding appropriately to it. We're tailoring treatment in a way that feels right for the patient and also moving and being mindful of the sleep principles and sleep regulations, because that's one of our roles, which is to be the sleep expert, to be the person that holds space while at the same time making sure that what we're recommending is actually going to be helpful towards the patient's goal.
That's really wise. Yeah. And like you said before, just to dig into it a little bit more with curiosity. So another question I get from people is, where do I find a CBTI practitioner? I know some places have long wait lists to get in. So what's a good place for someone to find CBTI, whether they're a referring clinician or they're looking for themselves? And is it different working one-on-one versus there's apps out there? What would you recommend?
I completely agree with you and other people that the amount of training and kind of exposure to CBTI right now is still relatively minimal. If you're in the Bay Area or you're California, then certainly here at Stanford Sleep Health Clinic, We offer both group and individual services for CBTI. And certainly there are a number of trained providers who are in private practice who can also provide CBTI. And then if you're outside of the California area, there might be some research to be done to see if any providers are trained in cognitive behavioral therapy for insomnia, to see if there's any support for that. There's certainly other options, as you noted, apps that provide cognitive behavioral therapy for insomnia. The research seems to suggest that it can be just as effective as individual and group treatment, especially for people who might have a bit more quote unquote straightforward insomnia disorder where the anxiety isn't too high and you're willing to give the recommendations a shot. So for the people who feel like they'd be nice to try a bit more of a step care model and try out some of the apps, knowing that just because you didn't do so well with the app, that doesn't mean that CBTI is not effective. Oftentimes it can be super helpful to have a clinician implement the process for you so that if it doesn't feel like it fit properly for you, then maybe then looking to find one of these places that offer cognitive behavioral therapy for insomnia.
What are some of your personal favorite sleep tips?
The two that come to mind immediately would be one, if you are having a poor night, the best thing to do is to do nothing. So oftentimes people who have a poor night, they try and compensate for that as much as possible. Like they'll sleep in, they'll take a nap, they'll rest all day, they'll cancel activities. And they all make so much sense in the short term. And at the same time, they contribute to this sort of insomnia trap where every day we're now having this sort of maintained sleep difficulty. So if as much as you can, in some ways, don't react to a poor night so that one bad apple doesn't have to spoil the bunch. And then this other tip that I think is important in some ways, that's more of a life tip than a sleep tip, is that we sleep to live. We don't live to sleep. Oftentimes when we struggle with insomnia, sleep becomes front and center of our entire lives. We're constantly thinking about our sleep, not being able to sleep, and how it's going to impact our next day. And when it comes to life itself, is that we can't necessarily put a pause on life because we have these sleep problems. And in some ways, like that preoccupation on sleep is not particularly helpful for the insomnia anyway. So I do encourage you, both in terms of when you're dealing with insomnia, to still engage in valued activities, but even after you're done with insomnia, you're treated for the insomnia and you're feeling good, that we don't always have to put sleep first. Like sleep is going to be a priority for many people, but sometimes partying or spending time with friends is a big thing, or sleeping in and being able to cuddle with your partner in the morning. That's totally fine. Naps are totally fine. So make sure that have these principles in mind and also weigh them with the relative influence and salience of all the other cool things that are happening in your life.
So good. Thank you so
Of
much.
course.
Where can people learn more about you and follow you?
I have a YouTube channel. It's called Dr. Parky Lau. You're welcome to follow me there. I also have a website. It's called simplymentalhealth.ca if you'd like to connect with me. And certainly my profile is on currently Stanford's Sleep Health and Insomnia Program's website. So feel free to catch me anywhere there.